Hello, friends. Welcome to the session of Conceptual Spine Connect today, where we are going to talk on the past papers or the past questions pertinent to spine. So, there was a question on the classification and management of osteoporotic fractures. So, both of them had 5 marks. But I'm discussing a bit more on osteoporosis because they tend to ask osteoporosis a lot. So, osteoporosis is low bone mineral density, which is caused by altered bone microstructure, ultimately predisposing patients to fragility fractures. Now, osteoporosis is a systemic disease which results in more bone mineral loss, changes in the bony architecture, which leaves the spinal column vulnerable to compression fractures, usually after minimal or no trauma. As per the WHO, the definition of osteoporosis is via the DEXA scan, the BMDs that we get. So a T score which is less than minus 2.5 is osteoporosis, and a score of minus 2.5 with a history of fracture is a definition of severe osteoporosis. Osteopenia are scores between minus 1 and minus 2.5. So since overall the life expectancy of the people is increasing worldwide, that is how the osteoporotic fractures are also increasing, which results in significant morbidity and mortality. The management of these fractures affecting the elderly patients is complicated by all the coexisting comorbidities, all the associated diseases like reserve chest function, diabetes, hypertension, the mobility is restricted, the scores of osteoporosis overall. Many a times these patients come with, CKD. These patients might be morbidly obese. So all this in elderly patients complicate the osteoporosis. They have functional reserves which are impaired and also the cognitive function as well. So even if you try and think of, treating one of the fractures in a patient whose cognitive function is impaired, so that also becomes a challenge. Osteoporosis can either be the cause of thoracolumbar fractures, which are non-traumatic, or it may be a contributing factor in the traumatic fractures. So, many a times a subtle amount of trauma, which will not cause fracture in other patients who are not having osteoporosis, might easily cause multiple fractures in osteoporotic patients. And it is a known fact that thoracolumbar area being a zone of high biomechanical stress, so there are a lot of times that patients do get non-traumatic fractures in this area of spine, categorically due to the high biomechanical stresses where the thoracic kyphosis gets converted into the lumbar lordosis. So when we talk about the vertebral fractures, the commonest fractures are due to osteoporosis. 50% of all the osteoporotic fractures are in spine. After that, the hip and the radius is followed. So overall of all the osteoporotic fracture, 50% of them are actually secondary to spine. I will request everyone to note down this global burden and make it a point to mention it at the start of your theory, because this will definitely give a good impression to the examiner. So you do mention that in the latest statistics that was done in the year 2023 and 24, 9 million fractures annually worldwide were seen osteoporotic ones. The total daily loss was 5.8 million, which was 51% accounted for fractures that occurred due to osteoporosis. Studies have suggested that one vertebral compression fracture increases the risk of the future such fractures, which are osteoporotic ones. The patients which are having osteoporosis, generally in such cases, there is a five-fold higher risk of developing another fracture. And similarly, if ever, as the number of fractures increases, so that is how the chances of having subsequent fractures keeps on increasing when we talk about osteoporosis, which may even reach 12-fold. Risk factors for the vertebral compression fractures, which are modifiable and non-modifiable. Modifiable ones are alcohol consumption, tobacco use, osteoporosis, estrogen deficiency, menopause, hormonal causes secondary to bilateral salpingo-oophorectomy, premenopausal amenorrhea, impaired eyesight, so that will also cause some amount of injury, I would say. Physical activity which is insufficient, low body weight, or even morbid obesity, dietary calcium deficiency, vitamin D deficiency. Non-modifiable ones are advanced age, female sex, Caucasian race. Why female sex? Because after menopause, there is generally the protective effect of the hormonal cycle goes away. Susceptibility to falling, history of fractures in adulthood, and history of fractures, especially osteoporotic ones in a first degree relative. So when we talk about the clinical symptoms and signs, back pain is the commonest in the elderly patients. Most fractures can go unrecognized because most of the time the symptoms are attributed to degenerative change by the patient and the family. This is particularly so as the osteoporotic fractures classically would occur with very small trivial activities like bending, walking, lifting relatively light objects, and even I have patients who get the fractures after coughing, sneezing, while even sitting in the car with a sudden break that is given. And in fact, I had one patient who just had a fracture while she was lifting the quilt. So these fractures with such uh, trivial activity, I would say, can also happen in unstable ones as well. So, this might go unnoticed and might also be attributed to a degenerative or a senile change or a geriatric change. Neural compression might happen due to retropulsed fragment. Multiple vertebral fractures can result in loss of height, exaggerated kyphosis, spinal deformity, globular rounded kyphosis. Majority 60 to 75% occur around the thoracolumbar region. Transition zone, as I told you, from a thoracic kyphosis to a lumbar lordosis and a more rigid thoracic kyphosis to a mobile lumbar area is the reason because of which these fractures happen in the thoracolumbar area predominantly between T12 to L2. And this causes the other areas of spine also to become more prone for the fractures because as we discussed, once they develop a fracture, the chances of having subsequent fractures increases significantly. What are the consequences? The acute pain of the fracture lasts for 4 to 6 weeks with intense pain at the fracture site. Chronic pain may also occur in patients with multiple vertebral compression fractures with height loss. As there is height loss, patients experience discomfort from the rib cage pressing downwards from the pelvis. Patient would develop an exaggerated kyphosis. The lumbar lordosis might also be obliterated, and the abdomen might become protuberant with prominent horizontal skin fold creases. So whenever the thoracic space is reduced, so the exercise tolerance goes down, and the reduced abdominal space may give rise to early satiety and weight loss. So, since the thoracic space is reduced, the overall the tolerance goes down, the breathing capacity is reduced, the abdominal space goes down. There is a significant transverse crease that they develop, they bend forward because of the exaggerated kyphosis, which causes early satiety and weight loss. Sleep disorders might also occur. They lose a self-esteem, self-care becomes difficult. They are often depressed, which causes increase in the mortality. So this is how the deformity develops. There is a height loss. This is a normal patient, and this is a patient with multiple vertebral compression fractures secondary to osteoporosis. So there is a height loss. Upright posture is not possible. There's a pulmonary function loss because of the anterior wedging of the spine. The 12th ribs basically rest on the iliac crest, so they also become a source of pain. There is a narrow gap between the ribs and the ilium. The abdomen becomes protuberant. Distension, constipation, early satiety are something that follow because of the compression of the abdominal reduced space as well. So how do we investigate these patients? First of all, we ask for the X-ray. What do we see on the X-ray? We see localized collapse, wedging, kyphosis. So kyphosis is basically the increase in the amount of angle in the thoracic spine, or even there might be a focal kyphosis in the lumbar spine. The vertebrae can become fractured and they might become wedged. Cleft sign, which is basically something that you see over here on the dynamics X-rays better, as you see on this right image over here. So cleft sign is important because that tells us whether the fracture is united or not, and also gives us an idea about further increase in the fracture collapse and the morphology. Kummel's disease again is a sign of non-union and pseudoarthrosis. Generally, this is better seen on a dynamic X-ray rather than a stationary X-ray. So MRI is basically done to identify the neural compression and the cord signal changes. Fluid cleft signs, which suggests of a pseudoarthrosis, it is used to identify also old fracture versus a new fracture. MRI is in fact the investigation of choice because many a times we see on the X-ray that the fracture is there and we are not sure whether it's an old one or a new one, and we are sure about that once we do the MRI. Along with the presence of vertebral fractures, the age of the fracture should also be assessed to determine whether the present fracture is responsible for